Please, shall we start? It's 3:15, so let's start, please.
Yes, sister.
Yeah, the other time we started talking about the pelvis. Please, shall we have a feedback from anybody with the description of the pelvis? Please, what you learned, what you all shared, so that we can continue, because it is left with the pubic bone and the sacrum that we are to describe, so that we complete the gynecoid pelvis. We are getting to when we are 300, we start. So let's hear from you. Now that I know your names. Philomena Tete. Philomena, make a summary of the pelvis that we discussed last week. Give me a feedback. Philomena Tete, please, we are waiting for you. Hello, Philo. Yes, anybody? Philomena Tete, are you there? Yes.
Yes, yes.
Okay,
Please,
go ahead. Good afternoon. Good afternoon.
Please,
Go ahead.
We talked about the female pelvis, the bony pelvis. We said it's like a basin structure. Remember? Then it consists of 4 bones, which are the 2 innominate bones, 1 sacrum, 1 coccyx. Then
please go on.
Oh, okay. Then when we also talked about the innominate bones, which also consists of 3 parts, which we have the ilium, the ischium, and then the pubis.
Whoever has started this noise, please remember, if it continues like that, it's like we are going to disturb the class and we'll put you in the waiting room. So please, mute yourself. Who is this person? Let me check. Agnes, mute yourself. Okay. So, Flo, you have said something. Olivia, Paul, please. Yeah. Tell us what you heard about the description of the gynecoid pelvis. Please go ahead. Anybody? Hey. Anybody with a description of the gynecoid pelvis?
Yes, sister.
Yes, let's hear you.
Please, I'm Preaching Rosemary.
I'm Preaching,
so,
yeah.
We said that the pelvic is a base-like structure that is situated at the below the vertebra, which is is a base-like structure that is situated at the vertebral column, and then immediately after, below the fifth lumbar vertebra. And then we said it functions as it supports the weight of the body. And then it also creates a cavity for other organisms. Organs, sorry. And then we talked about that makes up a pelvis. We said we have 2 innominate bones, 1 coccyx and then 1 sacrum. That's build up a pelvic. And then we said the innominate bone is made up of 3 bones, which is the ilium, the
ischium,
and then
the pubis.
Okay, and the pubis, yes. Sister, that's what I can say. And then we said
Thank
the
you
ileum
very
is
much.
made up of the ileum is made up of it's a smooth comb. Sister, it's okay.
She doesn't
Madam,
want
please,
to
I want to
communicate.
help.
Help, go ahead and help.
My name
Go
is
ahead.
Boabin Bennett.
Okay.
Madam, please, we talk about the bones, the female pelvic bones, and we said that the bone divided into 4 bones, and we have the 2 innominate bones, the sacrum, and then the pelvis, the caucus. And we said that the 2 innominate bone is divided into 3, which is the ilium, ischium, and then the pelvis. And we also go ahead and talk about the ilium. And we said the ilium, it has a crest, which is called the iliac crest. That the flare upper portion of the 2 innominate bones. And then we said that when you go posterior to the ilium, we have 2 projections. The first one is called the posterior superior iliac spine. And 2.5 centimeters below, we have the posterior inferior iliac spine. And when we come anterior, we also said that we have the anterior superior iliac spine, and the 2.5 centimeters below, we have the anterior inferior iliac spine. And we said the iliac spine, it have a 2 surface. The medial surface, it has a concave shape, and that concave shape is called the iliac fossa, which is smooth in surface. And when you go posterior, it also have a rough surface which attached itself by the gluteal muscles.
Finish up.
Okay. Then the iliac, the ilium. Madam, that's what I can talk about the ilium. So
You have
someone supposed to come
spoken a
and help
lot.
me.
You have done
Sir,
so
please,
well.
let me also talk about the ischium.
Good.
This is Francisca Nyatefe Keta.
Good. Go ahead.
He said the ischium forms the lower 2 feet of the acetabulum,
Mhm.
and it has a thickened portion which is irregular in shape and is known as the ischial tuberosity upon which the body rests when sitting. You also said the ischium has an inner spine known as the ischial spine, which plays 2 roles. One is it divides the greater and lesser sciatic notch, and it also helps the ischium also help the fetal head to rotate during delivery. Please, that's all I can say about the ischium.
Thank you very much. You have all done very well. So that it's only left with the ascending ischial rami and the descending pubic rami with the same structure at the opposite side. It forms the pubic arch. Very good. Okay, so now let me quickly talk about the pubis, which we didn't mention, I'm very sure. So we said the pubis forms the lower 1/5 of the acetabulum. And look at the way I stress on lower 1/5. It should speak to you. So it forms the lower 1/5 of the acetabulum. Remember we said the ilium forms the upper 2/5 of the acetabulum, while the ischium forms the lower 2/5 of the acetabulum. And then the pubis, the pubic bone, forms the lower 1/5. So the whole thing is 5/5. Good. Now, the pubic bone, it consists of 2 flat bones that are joined together anteriorly by a part of cartilage known as the symphysis pubis, Its significance in midwifery is that the pubic bone actually forms the anterior wall of the pelvis. And it is shorter, measuring 4 centimeters in length. Whilst the posterior wall, whoever has started so early like this, me, when I'm teaching, I don't like this kind of disturbances. You divert people's attention, they can't concentrate. When it comes to examination, they are not able to perform just because of one person's disturbances. Please keep quiet. The one making noise, you have started too early. Please stop and pay attention. Josephine Inkum, be careful before I put you in the waiting room. Josephine Inkum. Okay. So I'm saying that the pelvis, the pubis, some people say os pubis is the same pubic bone. So yes, if that is what you want, I'll put you in the waiting room. I've already warned you. If you start like this, you are disturbing the class. I don't like that. Don't do that. You. I've admitted you. Please don't disturb the class. Please. Okay, so I'm saying that the pubic bone, there are 2 flat bones that form the anterior wall of the pelvis. It is joined together. That is the flat bones. It is joined together by a part of cartilage known as the symphysis pubis. And I said the significance of this symphysis pubis is that most of the pelvic measurements are taken from there. Most of the pelvic measurements are taken from the symphysis pubis. For example, if we are to talk about the anterior-posterior diameter of the pelvic brim, the anterior-posterior diameter of the pelvic brim, it starts from the promontory of the sacrum, which I'm going to talk about right now, to a point behind the symphysis pubis, about 1.25 centimeters. I say from the promontory of the sacrum, straight line to the posterior wall of the symphysis pubis, about a distance about 1.25 centimeters to measure the anterior-posterior diameter of the pelvic brim. Please take note of that. Okay. So that is the pubis that I'm talking about. Let's see the parts of the pubic bone. We have already said that it is joined together by a part of cartilage known as symphysis pubis. Now, it has a superior pubic rami. It has a superior pubic rami. That superior pubic rami joins, or it connects the iliopectineal eminence. If you remember the iliopectineal eminence, when we were talking about the ilium, we mentioned it. So it joins it, and that is what we call the superior pubic rami. Then below the flat bone, below the pubic bone, there's another ridge of bone that descends. It goes down. And as it goes down, it joins the ascending ischial rami. Please, I'm taking it again. I'm saying that the superior, the pubic bone has its parts, and we have the superior pubic rami, which joins the what? What does it join?
The
Iliopenial
Petinia eminence. Very good.
eminence.
Good. It tells me that you are paying attention. So the iliopetinia eminence. Then I said, below that same flat bone, below it, there's another ridge of bone known as the descending pubic rami, which joins the ascending ischia rami. And with similar structure at the opposite side, the pubic arc is formed, and it inclines at an angle of 90 degrees. So now, its importance in midwifery is that when you conduct vaginal examination, you should be able to ascertain whether the pubic arc is inclining at an angle of 90 degrees. Other than that, I think I said this last week. Other than that, what will happen is that if the angle is below 90 degrees, for example, it's 60 degrees, as in the case of android pelvis, in that case, it will affect the passage of the baby through the birth canal, especially during the second stage of labor. Because the area that the baby is going to pass is constricted. There's contraction there. There's contracted pelvic outlet. Hence, the pubic arc is not inclining at 90 degrees. And if you're a midwife, you should be able to know. You should be able to know. We shall come to that, okay? So that is the pubis. We have superior pubic rami, we have descending pubic rami. Then we have a part of cartilage joining the two flat bones, which we say should incline at an angle of 90 degrees. Any question, please, before I move on to the sacrum and then the coccyx?
Please, the part
Yes,
again.
HAJIA.
Yes, go ahead. Whoever is asking.
Please, I wanted to be sure if the ascending pubic rami can be called the superior pubic rami also.
Yes.
Oh, okay.
Okay,
Yes.
so HAJIA, please, the part of the pubic, do you have only two? Like you said, super pubic rami and then the ascending. That's the only two that we have.
No, I said superior. The superior pubic rami is there.
Okay.
The superior pubic rami joins the iliopetinia eminence.
Okay.
While the descending pubic rami joins the ascending ischia rami.
Okay.
And so similar structure at the opposite side, the pubic arch is formed. I hope it's clear.
Yes, please.
Now, with the formation of the superior pubic rami, the descending pubic rami, and the ascending ischia rami, the obturator foramen is formed. Please take note of this. Sometimes it appears in objectives and it's like students don't know which one to choose. But it's okay. It's so simple.
Please, can you take it again, please?
I'll take it again.
Okay.
I'm talking about the formation of what you call obturator foramen. Please, the one who projected the pelvis, the other project it right now. Project the pelvis, and then let's see if they can appreciate it well. So I'm saying that the formation, because sometimes we can ask you, which of the following bones of the pelvis constitutes the formation of the obturator foramen? In fact, it is for the passage of nerves, blood vessels, and lymphatic. And in fact, it is obturator nerves. They pass through the obturator foramen to supply the pelvis with nerves and other blood vessels. So I'm talking about the formation of the obturator foramen. I said it is formed by the superior pubic rami superiorly, then the descending pubic rami, of course, the ascending ischial rami is also part. They constitute the formation of the obturator foramen, which is the come again.
Sister, please, we are a little confused here.
Why?
So
The
HAJIA, please, I
ascending and
wanted
the
to ask
ascending.
Stop, please. So
that
if I
the formation
understand well.
of the obturator for foramen,
The network is
and
breaking.
it consists of the superior pubic rami, then the ascending pubic rami, then the ascending
The
ischial
descending.
rami.
Descending.
No.
Descending.
Descending pubic rami.
You said the superior pubic rami, the descending pubic rami, then the ascending ischial rami. Am
Excellent.
I correct?
Ischial
Yes,
spine.
you are right.
Thank you. No,
You are
ischial
right.
rami is not spine.
Ischial rami, yes.
Yes.
Thank you.
As simple as that. As simple as that. Erica, upon project the pelvis for me. I don't want to miss this thing. So you project the pelvis and then let's see if people who understand it. But I think it's so clear. We have all seen pelvis before. We have handled pelvis before. So just more that hole, that foramen that you can see between the superior pubic rami and then the descending pubic rami and ascending ischial rami. That is what we are talking about. It's called the obturator foramen. It is for the passage of obturator nerves and is covered by obturator muscles. So that is it. Let's continue. Let's continue. In fact, when you see it physically, you realize that it's the descending pubic rami and the ascending ischial rami are one bone. I mean, are fused together. It is one bone. But ideally, there are two bones that are coming together. You see it to be one bone, but you can clearly see that there are two bones because one is descending, one is ascending. And they meet and it forms, the opposite side forms the same thing, and then the pubic arc is formed, which inclines at an angle of 90 degrees. Okay, let's move on to the sacrum. Please picture the pelvis from posteriorly. The posterior wall of the pelvis is formed by the sacrum. True or false?
True.
True.
True. True.
True.
It is true.
True.
Nothing is going to.
True.
Yes.
True.
True.
Okay,
Yes,
let's
true.
continue. So I'm saying that the sacrum forms the posterior wall of the pelvis. It is made up of 5 sacral bones that are fused together. It is formed by 5 sacral bones that are fused together. It is shaped like a wedge, or simply you can say it is triangular in shape. It is triangular in shape. It's shaped like a triangle. And you know every triangle has a base and it has an apex. Every triangle has a base and it has an apex. So with the sacrum being triangular in shape, the base points upwards and the apex points downwards. Are we together? Hello, ladies and gentlemen.
Hi.
Hi, Haja.
We can see the pictures. So.
Hi.
Okay.
Haja, please, we can see
Please
the
take it
pictures.
again.
The sacrum.
Yes.
I said the sacrum is a triangular shaped structure or bone that forms the posterior wall of the pelvis. What are the vertebral bones forming it? The sacral vertebra. The sacral, 5 sacral vertebrae forms the sacrum. Superiorly, please, I'm using the prefixes superior, inferior, anterior, posterior, lateral. I told you every organ that we ask you to describe, that's how you go by it. So that the layperson can easily identify that structure you are describing. So the sacrum, I said superiorly. It is joined by the 5th lumbar vertebrae. Please take note of it. The first sacral vertebrae joins the 5th lumbar vertebrae to form the lumbosacral joint. To form the lumbosacral joint. If I were you, I would write it down. At least you jot it down in your notes so that you can remember.
Haja, please take it again.
Yes.
Which one? Okay, take your time and follow it again.
Haja, please take it again.
I'm taking it again.
Okay.
I'm describing the good. Somebody has the pelvis is there. Good. I'm describing the sacrum. Have you all seen the sacrum?
Yes.
Okay. Okay. And I'm saying that the sacrum forms the posterior wall of the pelvis. In fact, it measures 12 centimeters deep. It measures 12 centimeters in length. That is what I mean. While the anterior, we said it measures 4 centimeters, the pubis. But posterior, the sacrum, that forms the posterior wall, is formed by 5 sacral vertebrae. It is formed by 5 sacral vertebrae. So I'm talking about superior, inferior. I'm not going to talk about superior, inferior, anterior, and posterior. And each aspect that I mentioned, it has a special function that it performs. It has special function that it performs as far as midwifery is concerned. So let's hear. Superiorly, I said the first sacral vertebrae joins the 5th lumbar vertebrae, and you can see, the lumbar. Sorry, you're cold to see. So, superiorly, I said the sacrum joins or articulates with the 5th lumbar vertebrae to form the lumbosacral joint. Now, the anterior part of the first sacral vertebrae, where it joins the 5th lumbar vertebrae, has a projection. Please, I'm taking it again. I said the anterior aspect of the first sacral vertebrae, where it joins the 5th lumbar vertebrae, it projects inward. That portion has a projection. It projects inward, and it is known as the promontory of the sacrum. Promontory of the sacrum, or some books will say sacral promontory. Sacral promontory.
Please, Aisha, take that one again. Auntie,
Which one?
please take it again.
Please, who? Yes.
The anterior aspect of the sacrum.
She's coming. Okay. Okay, you. Come. Oh, wait.
Please, she said that with the anterior aspect of the first sacral vertebra, where it joins the fifth lumbar vertebra, it projects inwards to form the promontory of the sacrum. HAJIA, am I lying?
You are right. You are right.
Please, are you okay?
Please go over again.
The anterior aspect of the first sacral vertebra, where it joins the fifth lumbar vertebra, it projects inwards, then to form the promontory of the sacrum.
Of the sacrum. Thank you very much.
You're welcome.
Yes, that is it. Is it clear, please, ladies and gentlemen? Is it clear? Can I continue? Oh, my dear, I'm saying, oh, what she said, she's right. I'm saying that you see the, I don't know. Oh, but I think it's so clear. Look at where the diagram, look at the diagram.
The anterior aspect of the first vertebra, where it joins the fifth vertebra. We want the continuation.
You see, the anterior aspect, you see, yes, it projects inward.
Then it projects inwardly. That projection, it forms the promontory of the sacrum.
Exactly, that is it.
Of the sacrum.
Yes, it forms the promontory of the sacrum, or the sacral promontory. You can choose to call it sacral promontory or promontory of the sacrum. I hope it's clear. Look at the blue line, where they have used the blue marker, where the blue marker is ending. That is the promontory of the sacrum. Now let's continue. Let's see what is its significance in midwifery. That makes degree midwifery a little bit different, quite different from how do you call it, diploma, right? Because we go into details. So I'm saying that, what is the significance, what is the importance of the promontory of the sacrum in midwifery? Yes, any idea? Anybody?
Sister, please.
Madam.
I think that it projects more into the cavity of the pelvis. It obstructs labor.
Okay.
Okay, HAJIA, I would also like to say that during labor, it projects outwards to increase the cavity of the pelvis to allow the passage of the fetus and its membranes.
Actually, it doesn't. The promontory of the sacrum during labor does not move per se.
Yes.
But naturally, some people have their promontory of the sacrum being overprojected. Look, there are some women, when even she's walking, you can easily tell. Don't go about that in anybody or your colleagues. But I'm saying that there are some people, when they are walking, per the way that the buttocks is pushed backwards, the way that she has curved her, you can easily see that her promontory of the sacrum is actually projecting. So its significance in midwifery is that when it projects too inwardly, maybe naturally, when it projects too inwardly, it reduces the anterior posterior diameter of the brim. Somebody said it, but she said it reduces the diameter of the cavity. No. It's not the cavity. It's not the cavity. It is the brim, rather. If it projects too inwardly, it reduces the anteroposterior diameter of the brim, thereby impeding the descent of the fetal head. Thereby impeding or preventing the descent of the fetal head. Somebody said, can somebody type what for you? What do you want me to type? I'll type for you. What is it? What? Is it a promontory? Okay. So let's move on. So I'm saying that I'm going over. I'm saying that I'll take my time because some midwives don't know how to assess this promontory of the sacrum. So that every delivery, yes, every delivery, oh my goodness, you should be able to assess this promontory of the sacrum when you're conducting vaginal examination. So that on vaginal examination, there's a measurement. When we start pelvic measurement, I'll mention that, but I'm mentioning it bypass. When you conduct vaginal examination, every good midwife, you should be able to assess what you call diagonal conjugate. Please, if I were you, I'll write it somewhere. You should be able to assess diagonal conjugate. That will give you the measurement of the pelvic brim per vaginum. The diagonal conjugate is the only measurement of the pelvic brim that is measured per vaginum. Please take note of that. So that when you put your hand inside the vagina, you make an attempt after assessing the cervical dilatation. You make an attempt and they go under the cervix because the diagonal conjugate is the measurement from the promontory of the sacrum to the undersurface of the symphysis pubis. To the undersurface of the, so remember, the undersurface between your thumb and the index finger, that is your limit. That is where you can reach every vaginal examination. That is your limit. Your hand enters, and then outside there, it can only be under the pubic arc. Under the pubic arc. So from the distance from the promontory of the sacrum to the undersurface of the symphysis pubis, that is what you call diagonal conjugate. And it measures 12 to 13 centimeters. Can somebody write it down? Would you write it somewhere? You meet it somewhere and you can. I'm saying that I'm talking about the significance, the importance of this promontory of the sacrum. And I'm saying that its importance in midwifery is that in conducting vaginal examination, after you have done, we shall treat vaginal examination separately. But because I'm talking about the promontory of the sacrum, that's why I'm taking my time to explain what you call the diagonal conjugate. It is the measurement or a distance from the undersurface of the symphysis pubis to the promontory of the sacrum. At first, I said from the promontory of the sacrum to the undersurface of the pubic arc is the same thing. It is called diagonal conjugate. It measures 12 to 13 centimeters. Please take note. And that is why if you're a midwife, you have to measure your external diagonal conjugate by using your ruler on your fingers, so that you have your permanent measurement. Sorry. You have permanent measurement. Measure your fingers and know the length of your fingers. Using the middle finger. The middle finger, the ruler should be under your, between the pointing finger and then the thumb. Me personally, I have long fingers. So my external diagonal conjugate that I use to measure, I have 11.5 centimeters. 11.5 centimeters, that has been my measure. So I have long fingers. So that now that I know that the diagonal conjugate measures 12. 12 to 13 centimeters. If I put my hand inside the vagina in an attempt to measure the diagonal conjugate, and without reaching anywhere, my hand meets the promontory of the sacrum, then in my reports, I will state that that woman, her promontory of the sacrum easily reached at 11.5, because that is the length of my fingers. That is my measurement. So that I will say promontory of the sacrum, I'm talking about the woman that I've just examined. Her promontory of the sacrum easily reached at 11.5, meaning that her promontory is projecting too inwardly. And that's why my hand could easily hit it. Now, it tells me that if I allow this woman to deliver per vagina, either she's going to sustain 2nd degree tear or 3rd degree. Yes. But if I attempt to reach the promontory of the sacrum, which I will teach you how to do it when we start labor, if I attempt to reach the promontory of the sacrum, but my hand at 11.5 couldn't reach, it couldn't reach her promontory of the sacrum, then on withdrawal, I will say that promontory of the sacrum not reached at 11.5. Meaning that if my hand at 11.5, I couldn't reach the promontory of the sacrum of the woman, then it tells me that her promontory is not projecting. It means the anterior posterior diameter of the pelvic brim is adequate. And so I should encourage vaginal delivery. You see, I've taken my time to, I haven't described the sacrum yet too, but I'm taking my time because of this promontory of the sacrum. Some midwives do vaginal examination, but they don't assess the diagonal conjugates. They don't. So the next moment, mommy, she's chimming. She will push and push and push, and then you realize that she ends up with maternal distress. And some midwives will be beating the woman. I learned some of them, you slap their thighs. Then you shout them, Mommy, it is you. It is you. It is the fault of you, the midwife. You didn't do proper pelvic assessment. You are allowing her to push. Meanwhile, her promontory of the sacrum is projecting. Well, yes, please, who is that? Hey, Brown. You see? Meanwhile, you didn't do proper assessment of the pelvis. You didn't assess the adequacy of the pelvic brim where the baby will have to enter. Now you are slapping the woman's thigh. You are shouting at her. Is it her fault? It is rather the fault of you. You should have identified it. Thank you very much. So let me describe the sacrum. Is it okay? Is it okay? I'm sure majority of you haven't ever checked there. They haven't measured. You haven't measured your fingers.
Yes, please, it's okay.
Come again. It's okay.
Yes, please.
You yourself, your diagonal conjugate, your internal measurement of your fingers that you use to assess the diagonal conjugate. What is the measurement? What did you get so far? What centimeter have you been operating with? Obviously, say to yourself, you haven't measured your fingers. Tell me, I haven't done it. I'm not going to do it.
We haven't done it.
We haven't done it. I'm not going to do it.
Yes, we haven't done it.
We haven't Please talk for yourself, not all of us.
Thank you very much.
Thank you very much for teaching
I've not
us.
done it before.
Okay.
Hey,
Thank
Ajia,
you
wait
very
there,
much. Okay.
Ajia,
So,
thank you.
Ajia, please. So, hello, Ajia.
Yes,
So
madam.
please, when you check and it's a setting, it doesn't mean that you are hurting the client. Yes. You see, because some of us we have big fingers. Yes,
No,
please.
if you measure, the least you can get is 12.5. You will read that 30, no.
13.
The least, yeah.
Now,
the least you can get is 12.5. Yes, no matter how long your fingers are.
Okay. Thank you.
So try to measure it so that you don't inflict undue perineal tear on the patient. Don't do that.
Yes.
Don't do that.
Sometimes we hurt them.
Yeah.
Thank you, Ajia. Thank you very much.
Yeah, welcome. So we have been hurting our patient, and so that those of us who are fan of shouting at patient and then slapping their thighs and that kind of thing, you will stop. It should be the thing of the past. It's not the making of the client. It's not the making of the client. It's you rather didn't do your assessment well. Okay, let's move on. So now the sacrum. So superiorly, we have spoken about the promontory of the sacrum. Let's see the anterior or inferior. So it should be superior, inferior, anterior, posterior, then lateral. Then we are done with the description. So inferiorly, the sacrum joins the first coccygeal bone to form the sacrococcygeal joint. I'm saying that inferior, please, those of you who don't have severe varus, look for severe varus, because you cannot understand and appreciate midwifery and enjoy it like the way I enjoy midwifery. I enjoy it so much. Midwifery, the papa. Yes. The papa. Yes. Yes. I like it. I like midwifery. Yes. So I'm saying that inferiorly, the sacrum joins the first coccygeal bone, the coccyx. It joins the coccygeal bone. And its importance in midwifery is that during second stage of labor, the coccyx tilts backwards. It tilts backwards to increase the anterior-posterior diameter of the pelvic outlet. Take note. During second stage of labor, the coccyx, per its joints, per its articulating surface with the last sacral vertebrae, it tilts backwards. It goes up back. It causes what we call the give. It causes the give of the pelvic outlet, which will increase the anterior-posterior diameter of the pelvic outlet to facilitate the passage of the baby's head through the pelvic outlet. So that is the significance of. I'm talking about sacrococcygeal joints. I said it is formed by the last sacral vertebrae, that is the fifth sacral vertebrae, and then the first coccygeal vertebrae. And I said that its importance in midwifery is that during second stage of labor, this joint, this sacrococcygeal joint, the coccyx moves backwards. It tilts backwards. And when it tilts backwards, it increases the anterior posterior diameter of the pelvic outlet to facilitate the passage of the baby. So those of you in the delivery suite, if you had observed closely, you see that when it gets into second stage of labor, that is where the patient will be shouting the more. Some of them will complain, they can complain and directly said, me too, me too. She's complaining of the coccyx. Look at a whole bone moving backwards. Can you imagine? Now to what will boom our men. Oh, boom. Hey, very serious. You're waiting for the day that the patient will send a midwife to court. Why? Because you slapped me when I was pushing. When I was in labor, you beat me. I learned some of them even have a kid in the delivery room. If you misbehave, please, if you are that type, stop it, because if you do that, God will not forgive you. A whole bone is moving backwards. A whole bone is tilting backwards. It causes pain. It will be painful. So if the woman is shouting, you have to talk to her. Talk to her. Madam, it shall be well. Is that your baby's head that is pressing? You see, it shall be well. Your coccyx is pushing backward, even though she may not understand what the coccyx is. But at least say something for her to understand that a whole bone is moving backwards, and it is a natural phenomenon. And so she shouldn't worry. It shall be well. Madam, who say you are in pain? I bear the pain with you. You'll be fine when the baby comes out. That is how to talk to the clients. And not to shout at her, or let alone slapping her thighs. May God forgive us if we have done that before. May God forgive us.
Amen.
Yeah, He'll forgive us.
Amen.
Probably you didn't know much. Okay. So that is the inferior aspect of the sacrum and the coccyx. Now let's talk about the anterior superior before we come to the lateral. Anterior, yes, dear.
Okay. So please, my network was breaking. You said inferiorly, the sacrum joins the first coccygeal joint.
Bone.
The last. You said the.
Please, whoever heard me, can you repeat it to her?
Okay.
So please, HAJIA said that inferiorly, it joins the first coccygeal bone to form the sacrococcygeal joint, which tilts back during labor to increase the AP diameter, also known as the give of the pelvic brain, a pelvic outlet. Did you get it?
Okay, thank you.
That is it. Okay. So that is it. Can I continue? Can I move on? So anteriorly.
Yes.
Anteriorly, the sacrum is concave. Anteriorly, the sacrum is concave, and it is known that concavity is known as the hollow of the sacrum. The hollow of the sacrum. Okay. Let's see the importance, the significance of this hollow of the sacrum. The importance of this hollow of the sacrum. The sacrum is concave. It's concave. That's what I say. And I'm talking about its importance in midwifery. The importance of this hollow of the sacrum is that the fetus, please pay attention. Oh, somebody said we should write the inferior aspect. What have you been doing? Please pay attention, concentrate. Leave whatever you are doing. Let somebody else prepare the food for you. And then concentrate in the lecture hall. You are in the lecture hall. I need your attention. I need your attention, please. So I think it's clear. The lady also explained it. So let's move on. Other than that, we won't finish the pelvis today. So I said the anterior aspect of the sacrum is concave, and it is known as the hollow of the sacrum. The hollow of the sacrum, right? Let's see its importance in midwifery. The significance of this hollow of the sacrum is that it is where the baby hides its face during the second stage of labor. The baby, you see, as tiny as it is so sensible. So the baby hides its face in the hollow of the sacrum. That is one importance. Now, another importance of the hollow of the sacrum is that it also increases the AP diameter of the cavity. It helps to increase the anteroposterior diameter of the pelvic cavity. Now, talking about as the baby hides his face in the hollow of the sacrum during second stage of labor, remember The colon, the rectum, it is also lying in the hollow of the sacrum. Yes, that's where the hollow of the sacrum, the rectum is also lying. The rectum, the colon, is also lying in the hollow of the sacrum. Therefore, during first stage of labor, if you do vaginal examination and you know how to do VA properly, you feel if the rectum is loaded with feces, you feel it.
Yes.
You feel it, yes. And when you feel it, after assessing the cervical dilatation, if it is not up to 6 cm, then you have to give enema, plain water enema, to clear the rectum so that the woman will empty the bowels. Other than that, those of you in the delivery suit, you bear me out. Other than that, what will happen is that, remember, I said baby is coming to hide its face in the hollow of the sacrum. Sacrum means a rectum, physics, iron and main. What do you think the baby will do? Please, I want your contribution. What do you think the baby will do? Baby is coming to hide its face in the hollow of the sacrum.
With his face.
Rectum is there. Rectum is there. It is loaded with feces. It is in the second stage of labor. What do you think the baby will do?
The baby will suffocate.
The baby will suffocate.
It wouldn't suffocate. No.
Yes.
It wouldn't suffocate. When it is feeling suffocated,
it will smear the feces on his face.
Yeah.
It will come again.
It will force the feces to come out.
Great.
Yeah.
Thank you very much. Thank you very much. It will use that beautiful, yes, it will use that beautiful soft face to sweep, to clear the feces out. And that is what the babies do. And then you people say first twin. You say first twin is coming, give me toilet room. Who gave you that name? Who said you should name it first twin? Who said it is called first twin? It is not a twin. It is physics. It is fecal matter. Baby is coming to hide the face in the hollow of the sacrum. During the first stage of labor, you did the V. Cervix was not up to 6 cm dilated, yet you didn't give her enema. Baby will clear the rectum by herself or himself.
Yes.
Use the beautiful face and then sweep the feces out. That is why in managing second stage of labor, in some of you have to clear feces before the baby comes out. And sometimes too, you don't clean it well, and baby will lose the face and the mouth and the nose are all smeared with feces. Oh my goodness. Hey, the one who is making noise. Don't let me put you in the waiting room. Tell her, please, she's your colleague. Tell her she should stop what she's doing. So I'm saying that never ever allow the mother to go into second stage of labor with a loaded rectum. Now that you know that the hollow of the sacrum is where baby is going to hide its face, and if it is loaded with feces per the rectum, baby will use the face to sweep. Sometimes you bear me witness that sometimes fecal matter smears the baby's face. Oh, good God. You call yourself a midwife. What kind of midwifery are you practicing? What kind of midwifery are you practicing? To allow somebody's baby's face to sweep, to be smeared with feces. The third day, you see baby is having eye discharge. The baby's eyes is discharging. Passive discharge. All because you, the midwife, allow feces to be smeared on the baby's face. What kind of midwifery are you practicing? Meanwhile, you had every opportunity to have, empty the rectum for the woman by giving a simple enema. That's why when they pack the items during antenatal, we have to tell them they should add the bentoa there. Let them add the bob syringe to the item so that when she comes and the rectum is loaded, you can give enema before 6 cm to clear the distance. Other than that, sometimes you see baby comes out, you visit the baby, and then you see baby is having bruises. I don't know whether you have observed that. Baby is having bruises on the cheeks. Have you observed that? There are some abrasions or bruises on the baby's face. What do you think has caused that? It's the constipated stool that the mother was having. It's the constipated stool that progesterone causes relaxation of all plain muscle fibers, including the bowels. And so mother had constipation. And so that heart physics is what has rubbed the baby's face. The baby comes out and he's having bruises. Oh my goodness. What kind of midwifery are we practicing? Are we going to change?
Yes.
Are we going to change?
Yes,
Yes,
we are going to change.
we are going to change.
Yeah, we are going to change.
In fact, Ajia, we have changed.
Yeah, we are going to change.
Thank you very much. Thank
We
you.
have changed.
Thank
We
you
have
very
changed.
much. I like that.
Yes.
Change. So that all these things will be the thing of the past. So that your colleague who couldn't get the chance to come and do first degree, when you are changing, you are effecting changes in the delivery ward. You say, was it any day? Was what first degree any day? Who change it? Was it the enemy? Often I say free or crime.
It's
not today. Oba da ben ya oba catch you say. Kase red to my no say na. Enti e ma na ni ma. E dey be enima. Me chona me nya kwai. Ah.
Degree ni pe bit na.
Oba started that bay. Now bay effect changes. She doesn't want it's not easy to change. So I hope. Thank you very much, madam. Hello, dear.
Please, what should we put in the enema for it to help us empty the rectum?
Water.
Oh, plain water. Just plain warm water.
It's a plain water.
Warm water.
Plain to be warm.
A little bit warm to be there. I mean, to match with the body temperature.
But that's how the client will see you. So let's know who can. Now this is examination answer.
Yes, it is when you do V. You know the possibility.
You do the V, you feel it.
You feel it, yes. Especially if it is constipated.
Yeah, it's constipated.
The rectum is packed. If you feel that the posterior vaginal wall is roughened, it's irregular.
Okay,
please, Ajia.
It's full of
I use manual removal.
Please, Ajia.
Hey, manual remover, you put your hands inside.
Please, what of you if you use your fingers to melt it?
But we are saying that, the manual remover they are talking about is like her hand will be in the vagina, and then she will be sweeping the feces out.
Okay.
That's what he's trying to say.
So, but it will be painful.
It will be painful.
It will be uncomfortable
for the patients. You see. So we are saying that just give one bob,
then you add that one.
enema, and it will clear the rectum. So that is the anterior. Let's move on. So posterior.
Thank you very much.
You are welcome, dear. So posteriorly, the sacrum is roughened. Posteriorly, the sacrum is roughened, and it is for the attachment of the gluteal muscles. Please, I have all these things in the slides. Me right now, I'm not having any book with me. I'm not having. I've taught for more than 30 years, so I don't have to be using it.
Wow, mashallah.
Alhamdulillah. Alhamdulillah. So I want you to be like the way I'm also teaching, so that when you finish, you can come to the classroom and help us.
Inshallah.
Yeah, I want you to come and help us. You do your masters, and then you can come and teach us. Okay. Hello. Hello. Yeah.
Hi.
There are a lot of points. Yeah. There are a lot of points that I'm giving you that are not in the slides.
Okay.
You can't find them. Yes, you can. A lot of points I'm adding that are not in the slides. That's why when I'm teaching, I don't want people to be disturbing the group. So that there are some points you can jot down. Okay, let's see the posterior aspect of the sacrum. It is roughened and it is for the attachment of the gluteal muscles. Period. The posterior aspect of the sacrum is rough and it's for the attachment of the muscles of the buttocks. As simple as that. Let's see the lateral side. The importance.
Yeah, you gave us only two.
The importance of the back.
Yeah. No, yes.
The back. Posterior aspect.
The one that is yes.
I said
the fetus hide its face.
And then I said it increases the anterocutial diameter of the cavity.
Okay.
I said that. Now, posteriorly, the sacrum is roughened, it's rough, and it's for the attachment of the gluteal muscles. Let's see laterally, the lateral side. Laterally, the sacrum, the first sacral vertebrae, has a flattened area known as the ally of the sacrum. Laterally, the lateral wall of the sacrum, the first sacral vertebrae, has wings known as the ally of the sacrum. Plural is Allah of the sacrum. Singular is ally of the sacrum. The ally of the sacrum joins the ilium. It joins the medial aspect of the ilium to form the sacrum. Oh, I'm talking about the lateral side of the sacrum. And I'm saying the first sacral vertebrae laterally has something like a wing, butterfly. It is flat. Have you? You see? Please look at the diagram. See the wing that I'm talking about. You see, it has stated there, wing, Allah of ilium. The Allah of So the Allah of the sacrum is what I'm talking about. I said it joins the medial aspect. It joins the medial aspect of the ilium to form the sacroiliac joint, which is the strongest joint in the whole body. Please, if I were you, I would jot it down somewhere. I'm saying that the sacrum has a wing. I'm taking it. I'm saying that the sacrum has a wing. It has a wing. Yeah, flattened surface, which joins the medial aspect. It joins the medial aspect of the ilium to form a joint. And the name of that joint is sacroiliac joint. And it is the strongest, subhanallah. Hey. It joins the ilium to form the sacroiliac joint, and I said it is the strongest joint in the body. Can I continue?
Yes, please.
Yes, please.
Yes, please.
Okay. Okay. So now we know that the strongest joint in the body is the sacroiliac joint. Now, still on the ally of the sacrum. Still on the ally of the sacrum. Please, whoever is making noise, tell the person to keep quiet and mute herself. You. Okay. So please, I'm saying that
sister, can you close your video?
Please mute yourself and close your video.
Please put them in the waiting room.
I think they're not ready to listen to them. It looks that they are not ready to listen to. They don't want to be part of this thing. Hello, are we together?
Yes.
Can I continue?
Yes, sister. Yes, please. Yes, please.
Okay. So I'm saying that the ally of the sacrum, congenitally, some people are not having the ally of the sacrum, or one of the ally of the sacrum is missing. Congenitally, some women are like that. Congenitally, the woman is not having the true ally of the sacrum.
Can you put them in the waiting room, please?
I've muted them because I want them to get this information. They will meet it somewhere, and so I'm muting them one by one. If they unmute and make noise, then I'll put them in the waiting room. Okay. So I've muted all of them. Whoever dares unmute and start making noise, then I'll put the person in the waiting room for good. Okay. So let's continue. I'm saying that congenitally. Josephine income. Be careful, eh? Josephine income. You. Okay, so I'm saying that congenitally, some women are lacking one of the ally of the sacrum. And there's a name for that. We call that type of pelvis as Naegele's pelvis. Naegele's pelvis. Those who have one of the ally of the sacrum missing. And it can affect the descent of the fetal head. And then when such people come,
HAJIA, please, the name of the
I said Naegele's pelvis.
Naegele's pelvis.
Yes. Some people will say Nageli. Naega. Naegele's pelvis is when one of the ally of the sacrum is missing. Now, sometimes to severe congenital malformation, you will get a woman with both ally missing. That type of pelvis, we call it Robert's pelvis. That type of pelvis, we call it Robert's pelvis. Please take notes of the two. Please take note of the two.
It again, please.
Yes.
Which one? I'm talking about when one of the ally of the sacrum is missing. We call it Naegele's pelvis. Naegele's pelvis. And I said some people pronounce it Nageli. Nageli's pelvis. Yeah. It's an obstetrician gynecologist. They saw that some women, especially those who are limping, during the ANC, somebody is coming, walking towards them, and she's having a waddling gait.
And Nadia, please, you said something. Maybe I didn't hear. Woman with both ally of the sacrum and missing. That's called the Robert's pelvis.
Yes, that is what is called the Robert's pelvis. Yes.
Okay.
When students meet it in objectives, it's like they become confused. They don't know which is the Naegele's, which is the Robert's. Let me give you a clue so that you can remember. We are talking about Naegele's pelvis. We said it's one of the ally of the sacrum is missing. What would let you remember is, Naegele starts with N, right?
Other spell it again, please.
Neglis.
Yes.
Please let her finish talking.
Oh, okay. No, but she spelled it, so I didn't get it.
N-A-E-G-E-L-E-S. Neglis pelvis. And I said, when both ally are missing, we call it Robert's pelvis. So I was trying to give you a clue as an adult learner, how you'll be able to remember and differentiate which one is the Neglis, which one is the Roberts. And I said, there are certain things I said, it's not on the slide. You can't get it from any book, but then adult learners, we have to devise means for you to understand. So I'm saying that Neglis, when you are spelling Neglis, it starts with N. It has a letter N inside. And then quickly, once you see Neglis, what comes into mind is one. When we are spelling one is O-N-E. So we have N here, we have N here, telling you that it is one ally that is missing. Now, when you come to Robert's pelvis, what will let you remember is that we are talking about two ally. So just say to you in your mind that, oh, Robert, he has been robbed. He has been robbed of both ally. Are you getting me? Hello?
Yes, we are getting you.
Yes,
sister.
Yes,
So that the moment you mention Robert, good. The moment you mention Robert, it means two ally have been robbed off. So that is Robert's pelvis. You can remember. Sometimes you have to link it that way for you to remember. That's all. Can I continue?
Yes, sister.
Yes, please.
Okay. So now, still at the lateral side of the sacrum, there are 8 pairs of foramina. 4 pairs of foramina. There are 4 pairs.
HAJIA, sorry.
Still on the lateral side.
HAJIA.
Yes.
Hello. Please, the Robert. What is the effect on labor? The Robert. The Robert pelvis. The effect.
Please, you said with the Neglis, it affects the descent of the head. So what about the Robert during labor?
Oh, during labor, it affects engagement. In fact, it causes reduction in all the diameters of the pelvic brim. I'm telling you. It causes reduction in all the diameters, both transverse, anteroposterior, oblique, will all be affected. So that you wouldn't know.
The person is not prone to DS or what?
Yes.
With the Robert pelvis.
Yes, with the Robert pelvis. Yes. So that when a woman is walking towards, that's why we said when they come to labor, the way she's walking or during the antenatal, she'll tell you, she'll speak to you, the midwife, that this woman, her pelvis may not be adequate enough. Look at her big abdomen and look at her waddling gait. We call it a waddling gait. Waddling. It has affected the way she walks. So that alone should tell you that no, I shouldn't try vaginal delivery. I shouldn't try vaginal delivery. And when you do proper pelvic assessment, you see that all her diameters, especially the brim, is reduced. It's reduced. So it will affect labor. So that you don't allow her to deliver per vaginum before she loses the baby. Okay, let's continue. So laterally, I'm saying that there are 4 pairs of foraminae, 4 pairs of holes at the lateral side for the passage of the sacral nerves. For the passage of the sacral nerves. And then the posteriorly, there was something that we left out. Which one?
You said on the lateral side, we have 4 pairs of foramina.
And it's for the passage of the sacral nerves. Sacral nerves. Yes, that's what I said. It's for the passage of the sacral nerves. And I'm saying that posteriorly, there's a hole. There's a hole that runs through the vertebral bones. for the passage of the spinal cord. It is for the passage of the spinal cord. And that hole is called foramen magnum. That hole is called foramen magnum. Foramen magnum. It is for the passage of the spinal cord. And when the spinal cord goes down, the nerves branches to form a bunch of nerves. The spinal cord, as it passes through the vertebral column, gets at the level of second and third sacral vertebrae.
Please, the passage of the spinal cord, you say is foramen what?
Magnum.
Foramen. The spinal cord passed through, the name of it.
Yes, as I pass it through that hole, and that hole is called the foramen magnum. Please, I've given you the slides, so it's all there. It's in the slide.
Please, can you ask your questions later so that she can continue? The distraction is too much.
It's too much so that won't finish.
Allow her to flow. Jot your questions later. You ask them.
Yes.
Oh my address.
Yes. Thank you very much. So I'm saying that the nerves and the spinal cord, it ends in a bunch of nerves known as the cauda equina. Cauda equina. CAUDAL. Cauda equina. It is in this cauda equina that anesthetists introduce spinal anesthesia to anesthetize the lower part of the body during cesarean section. I said it is in this cauda equina that anesthesia is introduced to anesthetize the lower part of the woman's body during spinal anesthesia in cesarean section. So that is its importance, its significance in midwifery. You see, when they are going to do CS, they ask the patient to bend and then they will introduce the spinal anesthesia. It is in the cauda equina that they are introducing the anesthesia. Ladies and gentlemen, that is all about the gynecoid pelvis. Any question? Any question, Ilias? Any question?
Yeah, please, I didn't get the...
You didn't get what? You didn't get what? Hello? You said you didn't get... Oh, say it, I will repeat it. The what? Yes, any question?
HAJIA.
Yes, madam.
Please, the latter part, the passage of the spinal cord, please, can you come again for me, please?
Oh, I said the foramen magnum is the hole through which the spinal cord passes. And I said that the spinal nerves, normally it ends at between the second and the third sacral vertebrae. And it forms a bunch of nerves known as cauda equina, through which spinal anesthesia is introduced during CS. This information is not on the slide that I've given you. Okay. So, Esther Tenkran, how may I help you? I can see your hand up. Esther Tenkran, your hand is up. How may I help you? Perpetua, your hand is up. Other than that, if you don't have any question, put your hand down.
Please, this Esther. Please,
yes.
Can you help me? You see, when you there is fecal matter in the rectum.
When there's fecal matter in the rectum, I said conduct vaginal examination to see if the cervix has not dilated up to this year. Then you give enema to clear the rectum. Because if cervix has dilated up to 6 cm and you give enema.
Oh, please, who is disturbing us?
I don't know.
Please, if you talk, we can't hear what sister is saying. We beg you.
That's why this person, they put her in the waiting room.
Still talking at her background.
I think she's the Is he the Zoom user?
Yes, sister, Zoom user. A Zoom user.
Yeah. I think I have to put her in the waiting room because she's not ready to mute herself. Let me put her in the waiting room. Now she's quiet. You should remain there. Okay. Okay. People's hands are up. What are your questions? Perpetua. Yes.
HAJIA,
Mabon and Kara.
concerning
Yes.
the foramen magnum, I'm a bit confused because I remember, I think with the fetal scar, there is a part like that. So I want to ask if it's the same thing.
Where is coming from the fetal scar?
The
It doesn't
foramen
hang, and it's the same foramen magnum. It doesn't hang there. It doesn't end there at the fetal scar.
Okay.
It doesn't end there. It goes down through the vertebral column. And that's why we say it's called foramen magnum.
Thank you.
It's the same foramen magnum. Okay. Any more questions? Jamila Said. Jamila.
Jana, please, I want to know how to the measurement of the sacral brim during vaginal examination.
You want to know the measurements?
Please, my HAJIA. I said I want to know how to measure the sacral brim during vaginal examination.
What you need to do is, please, I will take you through vaginal examination proper. But let me teach you small so that we can finish with this one. Because I have another class with other group. I think you are seniors. I'm going to teach them abnormal midwifery. And I don't know the time now. But what happens is that when you put your hand inside the vagina, you assess the cervical dilatation. You assess molding, you check the membranes. Your hand is still inside the cervix. But then in checking the diagonal conjugate, you bring your hand out of the cervix and go under the cervix. You go beneath, under the cervix, like you're going up to see if you can reach the promontory of the sacrum. If your hand touches it easily, once you know your measurement of your finger, you can come out to say the woman's promontory of the sacrum is projected to, those with projected promontory of the sacrum. I'm telling you, you put your hand there, you won't go not even 2 cm. Then you are meeting the promontory of the sacrum. Don't encourage vaginal delivery. After that, you sit down and do bottom tailor. You will tear proper. 2nd degree and 3rd degree, you have to prepare to theater, which is the biggest loss. So that is it. I don't know whether I've answered your question. Have I? Saida, have I answered you?
Yes,
that's good.
Madam.
Okay.
Thank you.
Hello, HAJIA.
Okay. And is it Angelina? Yes. Yes.
HAJIA,
Please go ahead.
Please,
HAJIA, please,
about
I have a
the
question.
sacral promontory.
Okay, go ahead.
Let's say a woman during delivery, then you assess and realize that the sacral promontory projects inwardly. Will it affect the subsequent deliveries?
It depends on the
first delivery.
It depends on the size of the baby and the head.
The baby.
Yes, it depends on the size of the fetal head and the subsequent babies. You see, like, let me give you a typical example. Some women are short, their shoe size is below 4 cm. Are you getting it? And such short women, such short women, hardly would they go in for a short man. No. They always, what they make to follow a man who is tall. You see? Yes, it's true. So that, and you see that if you are sure that you're going in for that tall man, what do you expect your baby to be? The baby will take after the father. The baby is also too big. The baby is tall. You see? So definitely you end up with very big abdomen. And such short women too, their promontory of the sacrum are easily reached without apology to the short ones. Yes.
No problem.
A promontory of the sacrum is easily reached. And so with the abdomen also being big, the husband is a TikTok giant man. You don't have to wait. Prepare for CS.
Yes.
You do, I just said, pelvic assessment. You see that her ischial spines are projecting inward. Promontory of the sacrum again. You put your hand there, in no time, you meet her promontory of the sacrum. You want to assess the, what you call the pubic arc. It can't admit your 2 fingers unless you turn your hands. It can't admit because the pubic arc is also so narrow, so acute. Such a person, don't try vaginal delivery for anything. As you will lose the baby, she will also end up with vesical vagina fistula. What kind of midwifery are you practicing? Let's do the right thing. I'll
Hello,
take you
HAJIA.
through a journey of families when we start labor. Hello, madam.
Good afternoon. And please,
Good
I have a
afternoon.
question.
Go ahead.
My question is, when you do B and then in the whole of the sacrum, when you find out that there is feces in the rectum, sometimes the feces are very hard to the extent that you trying to use your 2 fingers to push it out. It cannot be possible. So in that case, what will you do? Because I've encountered the same issue before.
We are
Like
saying
after
that
doing
when
the
you try
enema,
to
you do the enema and then still sometimes unless the head crowns that you see that the feces are coming out and it's very, very, very hard, constipated stool.
and we are saying that madam, that is why we are saying that. It was still hard. It was there. At that time, patient might not have dilated HCM. Then we say, Adata, give warm enema. Enema saponis. That's the name, the full name. Enema saponis. Give the enema saponis to clear that feces. Because once you introduce the the ventura and then the warm water, definitely it will soften the feces. It will detach the feces, the hard feces from the rectum. Okay. And then you ask the woman, go and poo-poo in the WC. She go and empty the rectum so that you see the next 4 hours that you're going to do the VE, that physics is not there.
Okay.
Other than that, baby will use that phase. Baby comes out after delivery with that hard physics in the rectum. Though the physics will come out, baby will end up with bruises. Haven't you seen a baby with abrasion on the face?
Yes, I have.
Yes.
Okay.
You'll be wondering. Yes. You'll be wondering, how can that these babies' faces having bruises like that? It's constipated stool from the mother that you the midwife allowed the baby to sleep out with its face. And that is what has caused the bruises.
Okay.
I hope so. I like to promise you said you change. So I'm sure I'm waiting for that change. Change for me, change, so that we all enjoy midwifery together. Okay. So let me quickly tell you the types of pelvis that was discovered by CODeL and Molloy. Please write it down. The types of pelvis was discovered by CODeL and Molloy. CODeL is spelled CALDWEL. CALD, and Molloy is capital MOLLEY. That is CODeL and Molloy. They saw that though some women are walking about beautifully with good shape and that, yet they are having abnormal pelvis. That can affect their labor. They made that discovery. And so we have other types of pelvis. And that is, what are they? I think you know them. Let's brainstorm so that those who are feeling sleepy will be awakened.
Gynecoid pelvis.
Gynecoid pelvis is one.
Android.
Everybody mention your name.
Platyploid.
If everybody knows.
Pelvis.
Who are there? Please, I don't know.
One at a time. We are just making noise.
Please
One
keep
at a time.
quiet.
If you decide, if everybody talks at the same time,
Haja,
who will listen to the
please,
other?
we
Let
have
me call you.
gynecoid.
One at a time. We can't hear
So let me
anything.
call you. Let me mention your name before you talk. Other than that, the class is noisy. Jafar Amamata. Jafar Amamata. What are the types of pelvis that you know? Jafar, talk. Okay, Eliasu. Eliasu mentioned the types of pelvis. But Jafar, your hand is up. I'm calling you. Unmute yourself and talk. Huh? Okay, Eliasu. Yes. Huh? What? What? Gynecoid pelvis. Let me take it and then let's go, because the way you are responding, I'm not comfortable with it.
Oh, Haja, my hand is up.
Okay, Belinda, go ahead. Belinda, mention the types of pelvis.
Gynecoid pelvis.
You hear me? It says you have the gynecoid pelvis and the android pelvis, the platypeloid pelvis,
and then anthropoid.
And
thank you very much. Thank you very much.
Anthropoid, yes.
So these are the classifications of pelvis that was discovered by CODeL and Molloy. So we have the gynecoid pelvis, and the gynecoid pelvis is the normal, typical female pelvis. It is the normal, typical female pelvis. Then we have in fact, with the gynecoid pelvis, the brim is almost round, except where the promontory of the sacrum projects inward. So that's the gynecoid pelvis. Then we have the anthropoid. The anthropoid pelvis, the brim is shaped like an ape. You know ape? The chimpanzee. And it is normally seen in women who are TikTok. It is normally seen in women who are giants. Don't be diagnosing people, they will beat you. So, but if you see a TikTok woman, you know she's having, it's likely, not always, but most of the time they are having anthropoid pelvis. The brim of the anthropoid pelvis is like that of an ape. And the ape is what I said, the big chimpanzee, HAJIA. So that is it. Then we have the platypeloid. The platypeloid, the brim of the platypeloid pelvis is shaped like a kidney or a bean. It's a bean shape, or it is shaped like a kidney. So it has a longer anteroposterior, no, it has shorter anteroposterior diameter and then wider transverse diameter. That is the platypeloid pelvis. We yeah, mommy. Awo yeah, mommy. Awo why? Text me your media. So that is the platypeloid pelvis. Then we have the android pelvis. That is the male type of pelvis. A typical male type. So it means that some women are walking about, but they are having male pelvis. And if you are midwife and you are not able to identify it, that's why you force her to deliver through the pelvis with her big abdomen. Nothing spoke to you that the way her abdomen is, you do V, and you see that the ischial spines are projecting. Why? Because the brim of the android pelvis is shaped like a heart. It's like a heart shape. So definitely look at the way they draw hearts. So definitely she's having a contracted pelvic outlet. So knowing your findings in vaginal examination is very, very important. It's very important. So that is it.
Hello, Aja.
Hello, dear.
Aja, good evening.
Hello. Good
Hello,
evening,
Aja.
sister. Yes,
Aja,
sister.
please. I wanted to ask about the this thing, Robert's pelvis. You said there are those who has missing Allah. Those
The
that
two
has
ally are missing.
Two missing
yes,
Are not there.
yes, please. I wanted to ask, what can you see in physical assessments of a woman?
I said it. I said they have waddling gait. When the woman is walking towards you, it has to be detected during antenatal or when she's coming to labor. It has affected her gait. We call it gait. And I said she's having a waddling gait. Where waddling gait is, she's not having a straightforward way of walking.
Okay.
She's waddling.
Okay. I thought that one was the nagal pelvis.
Nagels too, they walk like that, but if it is Robert, it is exaggerated, abnormal way of walking.
Okay. Thank you so much. Okay, thank you.
Hello, sister.
Aja.
Hello.
Please, are there always like these kinds of pelvis, that's the Nagels and then the Roberts? Do they get it as always congenital, or sometimes accidents do happen for it to happen?
Oh, accident will not remove your destiny. Congenitally, it is like that. Accident will, but will accident take off a whole pelvis, ally of the pelvis out? And where will it go? Fracture?
Something like that.
And maybe fractured pelvis, that one is also different. That one is also different. So I'm still on the types of pelvis. Good evening, madam. Let me quickly finish with the types of pelvis. So I said that with the types of pelvis, I will answer you, but let me finish before it escapes me. So I also mentioned that there's a type of pelvis that we call gestominor pelvis. Gestominor pelvis. It is a typical gynecoid pelvis, except that all the diameters are reduced. Please take note of that. I'm still talking about gestominor pelvis. I say it is a typical gynecoid pelvis, all right. But all the diameters, that is transverse, AP diameter, oblique diameter, are all reduced. And it is normally seen in women who are petite, who are smallish. The very smallish woman, they have the gestominor pelvis. You see, when we were in the hostel, if you remember, those of you who are, I'm not abusing any structure, but I'm saying that sometimes in the hostel, if somebody is very smallish, you are not familiar with the person, but then you get to the hostel and then you see some slippers, very small slippers. Sometimes you wonder who wears it. So the first thing that you say is, na kwalabe na beja ni mpaboa wa hey. Sometimes don't we ask? Yes.
Yes, I'm asking.
I do ask.
Yes. Yes, even in the ward. Yes, it's not for Akwada. It's a grown-up woman. You see, but because of her stature, that is how God has made her. Then you realize that her pelvis is likely to be that of gestominor pelvis. Now, there's still another type of pelvis we call rachitic flat pelvis.
Sister.
Rachitic. Yes.
Sister, can you repeat that? Gestominor.
Sister.
I didn't say genital. I said gestominor.
Gestominor. Please, can you repeat?
Gestominor.
Gestomino, sister,
So
please
the
go over.
gestomino, okay,
Hello,
the
sister.
gestomino pelvis, I said it is normally seen in women who are short. And I said it is a typical gynecoid pelvis with all the diameters reduced. It is reduced from anterior, posterior, transverse, and oblique diameter of the brim, the cavity, and then the outlet are all reduced. Though it is a gynecoid pelvis, all right, but diameters are reduced, and that is what we call gestomino pelvis. Is it okay?
Yes, please. Thank you.
Have I answered your question?
Yes, please. Thank
yes,
you.
Please, I want you to spell the carotid for us. The molar and the carotid. The molar and the carotid.
CODeL and molloy.
Molloy.
CODeL. It is spelled CALDWEL. CODeL.
Okay, CODeL.
And the molloy is MO, capital MO, double LEY.
Okay, thank you.
Molloy.
Molloy and CODeL.
CODeL and molloy. Okay, so that is it. Ladies, I think it's time. What's the time now? Yes,
7
sister.
minutes left.
Are
7
these
minutes.
pelvis fall under the molloy and CODeL, the 6 pelvis that we have?
They discovered the 4 types of pelvis. Yeah.
So the 4 types of pelvis were discovered by CODeL and molloy.
CODeL and molloy.
HAJIA.
Molloy.
HAJIA, please, you mentioned rickety pelvis.
They didn't allow me to finish with this, so I've also stopped. Yeah, I said rickety. I said rickets, flat pelvis. It is as a result of lack of some vitamins, vitamin D. And normally, the rickety flat pelvis, that one is not congenital. It is an acquired type of pelvis. It's not congenital.
Oh, okay.
So that when the girl child is lacking certain nutrients, so that during your antenatal or postnatal clinic, do educate the mothers that they should take good care of their girl children. I mean, if you have a girl child, they should take good care of their girls. Because if the girl lacks those nutrients or vitamins, that will help her pelvis to develop. And then, unfortunately for that girl, she enters into a trade, a work that allows her to be carrying heavy loads, the KIA people. They will end up having this kind of rickety flat pelvis because of the carrying of heavy loads. It compresses on the vertebral column, and then the pelvis is, in a way, is getting flattened. So you educate them to take good care of their girl child. And then there's a type of pelvis we call Malaysian flat pelvis. Malaysian, it is seen in some type of brides. Please, it's all in the slide, so you can read it on your own. Now your question.
HAJIA,
yes,
please,
sister.
with the gestomino pelvis, he said it is found in those who are smallish.
Yes.
So I wanted to ask, is it with achondroplasia or those who are just smallish naturally, not
achondroplasia? The achondroplasia, they have all diameters reduced though, but achondroplasia sometimes they can deliver per vagina.
Oh, okay.
Yeah, achondroplasia sometimes they can deliver per vagina.
Okay. So with the gestomino pelvis, it is with those who are smallish.
Yes, women who are small, who are petite. The word that the books are using is petite. Women who are petite. Yes, who are petite. Yes, who are petite. They have petite smallish.
or smallish?
No.
Smallish, yes, yes. They tend to have just to minor
Okay, thank
pelvis.
you.
You're welcome.
HAJIA, good evening.
Hello.
HAJIA, good evening.
Good evening, sister.
Please, I'm having some confusion here. You know, when the woman is pregnant, she will be having that kind of waddling, walking
HAJIA.
when because of the relaxing, because of the hormones.
Please, with the platypaloid,
Oh, I think somebody is on the floor. Let us
please, with
finish.
the
Somebody is asking a question.
platypaloid,
All you know, I think I have to mute people. I have to mute
Please,
all of
so
them.
the question was, you see, when the woman is pregnant, because of the
Please, one
relaxing, the
after
woman
the
will be having
other.
that
We
kind of
can hear you
waddling.
all. One
Please,
after the
I'm
other.
muting all of you. I'm muting everybody so that if you want to talk, raise your hand.
Please, I'm the one talking, Mercy.
So I'm muting everybody, so unmute yourself and ask your question. The noise is too much. So if you can hear me, whoever is on the floor, mute yourself, unmute yourself and then talk. Unmute yourself and talk, please. Yes, go ahead, Osables. Unmute and talk, please. Hello? Go ahead, please. Osables. Unmute yourself and talk.
Okay, HAJIA, please, I was saying that when a woman is pregnant, you see, because of the hormone relaxing, the woman will be having that kind of waddling walking. So I wanted to ask, in comparison with the Robert and the Nagel pelvis, that kind of waddling, should we detect it when the woman is not pregnant with the waddling, or we should detect it when the woman pregnant?
When the woman, because of congenital malformation, even when she's not pregnant, that's how she walks. She's having a waddling gait all along. And so when she becomes pregnant and the hormone relaxes the pelvic joints and ligaments, getting to the 36th week of pregnancy, then it even worsens. It becomes worse. Okay? So if she's not pregnant, because the malformation is there, she will still be having a waddling gait. I hope you understand me. Is it okay? Osebonsu. Okay. Okay. Yes. Amida. Whoever wants to ask a question, go ahead. I'll mute and go ahead. Okay. Yes. Yes, please go ahead.
Yeah, I want to bring a contribution to
Okay, go ahead.
concerning the